around, and straight away I find the canal orifice. So it just takes that kind of orientation to have a little feel around. Tooth is slightly unusual. I think it's a little bit bent, and what I want to say is that I'm just going to annotate here on what I think the tooth should look like compared to what the tooth does look like. So I do want to wick out some of the irrigant here, because when I hook up the apex locator, I'm worried that the perforation palatally is going to sort of short circuit this. I'm going to use this Vitrabond. This is a GIC which is light cure, and I'm going to use these Acidos tips so I can place the GIC exactly where I want it. So hello, welcome to this week's Friday clinical case, and this case is a humbling one for me, and probably quite a difficult case to showcase, because essentially this is a endodontic treatment where I have made a mistake. And, one of the regular feedbacks that I get off a lot of the viewers and a lot of friends and people who watch the channel is I like to showcase my mistakes, because I think it's really, really important to recognize that, everybody's human and we will make mistakes. And I'm hopefully that this particular case will show you how to rectify a difficult situation. In this case, it's a perforation. But what I would say in my defense, this is an extremely difficult tooth to do a root canal on, and the patient was made fully aware at the appointment. This guy was actually an absolute geezer, so he was dead nice. He understood the risks of perforation. But like I said, hopefully by the end of this video, you'll understand the way in which we perforate teeth and how to manage it successfully. But before we get into the case, what I do want to say very, very quickly is that when we look at the metrics of the channel, over 50% of the people who watch these videos are non-subscribers. So if I could ask you to do one thing, it's simple, it's easy, and it's also free, and that's just to hit the subscribe button. I promise if you hit the subscribe button, it pushes me along, it shows support to the channel, and I promise you each week, each video will get better and better and better. And if you want to show the support even further, we've got a membership program here on YouTube. The membership program has early access to content. So if you love these videos, you usually get up to about 3 or even 4 weeks ahead with the videos. And also we've got exclusive content. We've got a fantastic endodontic access video on there. It's an hour long. It gives you all the tips and tricks on how to access a tooth for endodontic treatment. So let's get into the case. So first of all, I want you to show the periapical radiograph here. So this was an external referral essentially to a very, very good referrer who's down the road. She's a lovely lady. And straight away we can see that we've got an upper left one, and there is obvious apical inflammation around this tooth. There is also some kind of external inflammatory root resorption on this tooth, and also there's no obvious canal space. And I feel like this tooth has been accessed by the normal dentist, the referring dentist, and they couldn't see any obvious canal space. So quite rightly, this is being referred to me. Straight away with these cases, what I like to do is I like to take a cone beam CT scan. Now, what I would say is that a lot of endodontists or special interest dentists would argue taking a cone beam CT scan in these cases might not be worthwhile. I can see their argument for that, but I think in this case, what I like to do is I like to see if there's any obvious canal space on the tooth. So if we move over to this cone beam CT scan slices here, we can see that there is obvious canal space here. It also gives you an idea of how deep you should be going. So the measurement tools on the cone beam CT scans are pretty accurate. That's in contrast to the periapical radiographs where they're not so accurate, and you can have problems with sort of the orientation of the X-ray holder that can sort of elongate things. So measuring on periapical radiographs isn't great. It also gives me an indication of what the end looks like, because in a way, what we've got to do is we've got to make an assessment to see if this tooth is genuinely restorable or not from from a root anatomy point of view. So we can see here that the tooth is about 18 millimeters in length, and also the sort of point at where we are seeing obvious canal space is probably around maybe 12 millimeters, 13 millimeters. So this gives us about a bit of an indication when we come to access the tooth, how far to go down, and also if we take a working length measurement, we'd expect it to be about 18 millimeters, which is a very, very important point, which what we'll come to is how I kind of worked out that the tooth was perforated. So we'll move over to the to the video here, and I'm just checking the orientation. And in this case, I'm not going to place rubber dam on this tooth. I'm just going to make sure I access the tooth successfully before I do. And what I do like to do in these types of cases is just drill straight down the center of the tooth. Now, the problem with drilling down the center, of course, is you're going to affect the incisal edge, and this can affect the aesthetics of the tooth. But I feel like drilling straight down the middle of the tooth might reduce the risk of perforation. In this case, it didn't, of course. But I'm just checking the orientation. I'm using the high energy ultrasonic here to see if I am going to breach any obvious orifice, but I don't. And I'm just going to do a little bit more drilling, and I'm just checking my orientation here. I'm thinking to myself, maybe I need to be a bit more palatal, and just making a little bit of an assessment here. And now I'm thinking to myself, have I removed too much palatally? So there's always a bit of a way up, isn't there? And then obviously you can see here that I've made a bit of a bit of damage to the incisal edge, but make sure I'm straight down the middle. Straight away, I can maybe feel like there's some sort of orifice, so I'm just going to get a hand file in this orifice to see if I'm getting any kind of stick at all, and I'm not really getting any stick. I think when I've been using this high energy ultrasonic, I've created a false orifice, and I'm going to move over to my diamond tipped ultrasonics, and I, in this case, feel like I want to aim more palatal. This, of course, is where I get into trouble. But what I would say is, as I was editing this video, I actually was editing the first half of this appointment, and this is where I saw my reflection in where I was going wrong. So in this case, I'm going palatal, but I shouldn't be going palatal. And here is where, when we do the measurement check with a cone beam CT scan, is where we can check how deep we should be and where we are. So what I'm going to do is I'm going to have a little go with a hand file here just to have a feel around for maybe this kind of orifice, but I'm a little bit unsure about how deep I am, and sometimes it can be a bit disorientating how deep you are. So what I'm going to do is I am going to get my Mach 2 plugger, and I'm going to measure it to 12 millimeters. So this is about the length where it should be, as seen on the cone beam CT scan, to see where the obvious canal space is. And when we get our Mach 2 plugger here, we can see that we're not that deep at all, and I think we've got quite a fair bit to go, a bit more depth. So this is a great little way of doing like a bit of a depth gauge here with the Mach 2 plugger. And also what I notice is a bit of soft and affected tissues within this tooth. So I'm going to use a rosehead burr just to remove all that. I don't understand why there's soft affected tissue here, because the tooth is so calcified, but it's still, nevertheless, it's a good idea just to remove everything. And then we're having a little look around, just to have a see if we can see any orifice there. To me, at this point, it isn't obvious. But obviously on reflection, maybe there was something in the kind of mesial aspect of this tooth. But I've got to be really, really careful about orientation here. I'm really, really mindful that I am going a little bit off center. So we're just using really, really careful ultrasonic, diamond tipped ultrasonics here, just to try and go essentially straight down the center of the tooth. But when we're using water here, the water can pool quite significantly deep down in the canal, so I'm just going to use a couple of paper points here. And when we look into the canal orifice, we can see that we have gone a little bit further. So we can see the Mach 2 plugger here with the depth gauge has gone a little bit further, but we're still too far away from the suggested point at which the orifice is with the cone beam CT scan. So I'm going to move over to these needle tipped ultrasonics here. These are great for not removing too much tooth tissue, but you can create false orifices. So you've got to be really, really careful in this case. Again, I'm using a high energy ultrasonic just to clean everything out. And I'm just having a little dig around. And again, I'm slightly concerned of the fact that I'm sort of not in the right orientation. Maybe I'm a little bit too mesial. And what I would say is you want to be aiming for the white rather than the dark. So the white is essentially the sclerosed or calcified tissue, and the dark is essentially the dark part of the dentin. That's what the root looks like. It's dark. So I'm going to have another kind of fiddle around here with these diamond-tipped ultrasonics, giving it a bit of a clean out, maybe using a paper point to have a little look around. And now what I need to use is a thinner gauge tip here, because I am using these needle-tipped ultrasonic instruments, and they are creating a small hole. And the Mach 2 plug, as you can see here, is quite thick. So I'm using a DG endodontic probe with a rubber stopper on just to see if we're in the kind of right depth. And when we place this DG16 with the stopper on, we can see here now that we're kind of around the area of the right depth. And in this is the bit where it's really, really difficult, because if you are at the right depth, as say you see on the cone beam CT scan, and you're not feeling any orifice, might be an indication that you're in the wrong orientation. And I suppose on reflection, maybe I should have taken a cone beam CT scan at this point, but I've a kind of a feel around with my ham files, and I have another little feel around with the diamond tipped ultrasonics, and I feel like at this point here I'm straight down the center of the tooth. I feel like there is a bit of darkness here. And, on reflection, again, I feel like I didn't see this at the time, but I am definitely off center here, mainly because I'm following the darkness. The argument, of course, is there's no obvious white sclerosed tissue here, so you've kind of got to have a little sort of use your common sense, and sometimes in these cases, we are in the right orientation, and we do get the correct orientation of the instruments to get into the orifice. But I'm going slightly deeper here again with our ultrasonics. I'm being very, very, very careful, and I'm super, super mindful of a perforation. And I'm just being super, and also what you've got to be careful with these needle-tipped ultrasonics, you don't burn the tissue, and you don't put too much heat on these tips as well, because they fracture really, really easy when they've got a little bit of heat. And then we're just having a very, very judicious look with my ultrasonic tips, a little bit of cleaning, a little bit of a paper point, maybe a hand file, and just very, very gently moving further and further down. It's at this point I don't realize that I'm off center, and at this point I'm going to perforate it soon. But as I place my paper cone to length, I kind of have a look at the tooth. I feel like I'm within the kind of right direction of where I should be. However, this is the point where I am definitely going in the wrong direction. And in fact, I thought that this is the area where I should be going. So I am going to just change tack here. I'm going to feel like I'm looking straight down the middle of the tooth, and I'm using my diamond-tipped ultrasonics to go in the direction that I should be going in. I suppose in a way, I was going maybe a little bit too buccal in the other situation, but it's again, everything's with hindsight and reflection, and these types of cases make you learn quite a lot. So at this point, I can't find any obvious orifice for the canal space, and I am slightly concerned that I am moving quite deep here. And on the cone beam CT scan, we should have been about 12 millimeters where we've hit the correct length. So what I'm going to do is I'm going to take a GP cone, and I'm going to place it into the point where we are reaching with our ultrasonic tips. I put the GP cone in. And in this case, it looks like I'm kind of within the same orientation of the tooth itself. But this is where the biggest flaw of periapical radiographs show, is that if you're going too palatally and you're straight down the center of this GP cone, you won't see that you're going too far off. So in the first instance, it looks as if I am going down the center of the tooth, but actually I am going to palatal. And again, there's a massive argument to say that, we are... should be taking a cone CBCT scan. But when I pull the GP cone out, I can see that I'm about 15-16 millimeters. And again, that to me should have been a red flag that I was perforating the tooth, because we know with the cone beam CT scan that it's about 12 millimeters from that kind of orifice. And then I'm going to do a bit more deeper instrumentation, because I feel like I am in the correct orientation, remember, even though I am not. And then what I do is I get a size 8D finder and I have a little feel around, and then I feel this kind of breach. And I feel like at this point I have reached this canal orifice. So what I do is I have a little feel around. It feels like the file is actually within the canal space, and I hook up my apex locator here, and I can see that actually we are about maybe 16 millimeters. So what I'm going to do is I'm going to take a working length X-ray with the hand file in place, and at this point I feel like I am straight down the middle of the tooth. It looks like it's going along the sort of path of where the root might be, and I am quite happy that I have managed to file a canal space. So I'm giving myself a pat on the back, and I'm saying, well done, Sam. I'm telling the patient I'm amazing, etc., etc., etc. And I said to him, well, we've run out of time. We're going to dress the tooth, and we're going to get you back in. So I'm going to dress the tooth with non-setting calcium hydroxide, PTFE tape, and GIC. And like I mentioned before, when I edit these videos, I say the appointments are in two blocks. So I do an appointment and I save the video, and I get the patient back in, and then it's always edited in two slots. And as I was editing this tooth, I started to reflect on this, and I thought to myself, well, I was basically drilling into dark tooth tissue. So that's one thing I'm thinking to myself, was that right? I didn't really take a proper working length radiograph or a proper working length X-ray. And I'm thinking to myself, maybe I've perforated this tooth in the palatal aspect, and all of the X-rays that I've taken, essentially, it's just been down the long axis of the tooth. So the periapical radiograph has been perpendicular to all of my instruments, all of my checking, all my GP, all etc., etc., etc. So as soon as we get the patient back in the chair, I make him aware of the possible situation of a perforation, and I'm going to place a rubber dam on straight away. So in the first instance, what I want to do is I want to remove all the obvious temporary filling material. I'm going to remove the PTFE, but in this case, it's a bit difficult to remove the PTFE, mainly because there's a bit of an overhang there. So, it's a bit of a catch-22 with these overhangs, because sometimes you can remove too much tooth tissue. But once we've removed the PTFE tape here, I give it a good old clean out. And when I have a look at the tooth itself, I can see straight away that there might be some kind of obvious orifice, and I have gone to palatal. This is the great thing about non-setting calcium hydroxide. It obviously acts as an antibacterial property, but it also cleans up, and sometimes I want to say dissolves dentin, but it doesn't dissolve dentin. But essentially, it just cleans the inside of the root canal up. And what's essentially happened here is I've soaked this tooth in non-setting calcium hydroxide. I've cleaned it all out, and this has exposed a possible canal orifice. So I do want to just check the orientation or the length of this tooth. So I'm going to use a size 15K file. This is probably one of the best files to use. And then what occurs to me is that this is really, really, really short, which is hitting 0. And when we sort of marry up the file to the external surface of the tooth, I can see that it is super, super short, and it's measuring 16 millimeters. I also take a cone fit radiograph of this tooth at this length, and I'm hoping, I'm finger crossed, that this is at the end of the tooth, but it isn't. It's way short. So this is a strong indication also that we're at 0 with our apex locator, but the GP cone is showing quite far away from the from the radiographic apex. And in fact, this is an indication now that we need to take a CBCT, and we can see here that I have caused a very, 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 very small perforation with this tooth. And when we look at this, it's quite a significant amount of tooth tissue that I have had to sort of negotiate down. Also, what I want to say is the orientation of this tooth is slightly unusual. I think it's a little bit bent, and what I want to say is that I'm just going to annotate here on what I think the tooth should look like compared to what the tooth does look like. So I suppose in my defense, again, if I'm giving you lots of excuses, is that this is the reason why I think that I've got my orientation off. And in fact, going down the center of this tooth, drilling down the center of the tooth, drilling down the incisal edge of this tooth, in this case, probably wasn't the best idea. So we know the tooth's perforated, and like I say, once we opened up the tooth initially, maybe I can see an orifice here slightly buccally. So what I'm going to do is I know now that I can, I've got more orientation with this second cone beam CT scan, so I'm just going to use the diamond tipped ultrasonics just to reorientate, and obviously this creates water within the canal orifice, so I can't see down there, so I'm just going to use a paper point just to have a little feel around, and straight away I find the canal orifice. So it just takes that kind of orientation to have a little feel around. I do want to wick out some of the irrigant here, because when I hook up the apex locator, I'm worried that the perforation palatally is going to sort of short circuit this. So when I take the cone fit, when I take the working length radiograph, it turns out that the working length is 19 millimeters. And in this case, I don't usually do this, but I'm taking a working length x-ray, and we can see here now that we're at the correct length. So I'm happy that this is actually the genuine working length of this tooth. We're going to finally shape this tooth. We're going to use our 10 glide path file high flex. I'm going to use a size 25 variable high flex. Give it all a good clean out. Just got to be mindful that it's open. We're going to take our cone fit radiograph. Again, we can see that the cone fit radiograph, we can see the cone is right down the center of the tooth. It fits nicely to length. And when we take the cone fit radiograph, we can see the x-rays at the radiographic apex. So we've gone from disaster to everything's working out pretty well. So we're ready to obturate, but I obviously need to do my irrigation protocol. I've got to be really, really careful here, because obviously the perforation, I don't want to push any of the irrigants into the periapical tissues and cause a hypochlorite incident. You know, we've come a long, long way with this tooth, so I don't want to muck it up, and obviously don't want the two patients to be in pain. And then we're just going to dry the canal with our paper points, and I'm going to make sure that the canal is completely dry before we fill this. Obviously, because the sealer won't work very well if the canal space is really, really wet. And then before we obturate the main canal, I am going to do our perforation repair. I'm just checking the diameter of my MAC2 plugger to see if this is going to be able to reach down into that quite sort of narrow tube. And I'm going to use a Zmerg plugger creator here, and I'm going to push some bioceramic putty into this specialized sort of plugger creator. And the great thing about this is once you've filled up like this kind of little hole in the Z-Bug plugger creator, you then get your MAC2 plugger, and then you push it through the hole, and then it opens up like a pair of tweezers. And you can see here with this MAC2 plugger that now it's got a nice kind of little plug on the end, and that's just going to go straight into that hole. So we're going to place the putty into the hole. It's very, very delicate. Sometimes if you're not careful, it can get stuck on the sides and it can get a bit messy. And then we're just going to have a little dampen down with our MAC2 pluggers. And you want to make sure that you're pushing this down significantly, because what you don't want is you don't want any space in this perforation, because that where obviously bacteria can proliferate. You also want to be careful you don't block the main canal with the bioceramic, because that can be a bit of a tough one to do. Sometimes, however, you're sort of concentrating on one thing and then something else is sort of creeping up behind you, and we can see here that the canal space is now filling up with fluid. So what I want to do is just dry the perforation repair with some paper points just to dampen it down nicely, and I might take a little bit more bioceramic putty and give it a bit of a dampen down. And once we've dampened everything down and we've had a little look, we can see now that this perforation's quite nice. So we're going to do our final drying protocol in the main canal. We're going to make sure we dry this. I think the tooth has been quite badly closed up, so there's been a significant amount of inflammation that's built up with this tooth, and this is why it's taken quite a long time to dry this canal. And when we look now, we can see that the canal space is nice and dry and everything's looking great. So we're ready to do our final obturation of the main canal. I'm going to use one fill. This is a bioceramic sealer directly injected into the canal space. And once we have filled that all the way to the top, I'm just going to use my GP cone here, my matched GP cone, and I'm going to very, very gently sort of push this to length. I'm going to burn off the excess, and this tooth is going to have some whitening in it. So in this case, I'm going to make sure I'm burning off the GP way below the CEJ, and I'm going to fill this up with Vitribond, which is like your GIC, and this is going to make sure the tooth is ready for any kind of internal whitening. And if you leave GP above the CEJ or within the pulp chamber itself, it's a surefire way of making sure that the tooth will become discoloured if it isn't already discoloured. So once we've pushed it all down, I'm going to give a bit of a clean out, and then I'm going to use my paper points, and we can see now that we've got a nice obturation, we've got a nice perforation there, and everything is ready to be sealed off and ready to go. So I'm very, very happy with this. I'm going to use this Vitribond. This is a GIC which is light cure, and I'm going to use these Akidos tips so I can place the GIC exactly where I want it. And we can see now that we've got GIC over the perforation repair and the GIC. I am not going to fill this tooth conventionally, because obviously, don't forget, I've drilled down the centre of this tooth, down the incisal edge. So the patient actually complained that it looked a bit off. He was fine with it, of course. So what I'm going to do is I'm going to do kind of a hybrid approach here. I am going to repair the incisal edge with a proper composite. I'm going to make sure that all looks nice, but I'm also going to make sure I'm going to leave space for the internal whitening. So once we've repaired the incisal edge of this tooth, I'm going to fill the tooth with a PTFE and give it a bit of a clean up with the soft stone and obviously a bit of GI in the back. And when we look at the final cone beam CT scan, I'm super, super happy with this. I suppose if it isn't new to everybody, it might be new to everybody, that dentists struggle with making mistakes. I certainly struggle with making mistakes, and I suppose in a way, maybe a few years ago, this type of situation would have sent me down a sort of depressive episode. I would have felt like I was a failure, or I would have done something wrong. But I think on reflection with this case, the patient was fully consented and understood the situation, and in fact he was ready to have this tooth out, although he was super, super keen to save this tooth. And I did consent him for a perforation. Another thing to say is that a very famous endodontist, I won't say his name, had suggested that sometimes you've got to perforate a tooth to get yourself in the right direction. So, I would say, I don't know if I agree with that, but maybe I do agree with it in this case. But what I want to say to you is, if you've ever perforated a tooth, it's not the end of the world. We all make mistakes. And this is essentially why we consent patients. Because if I'd consented this patient and said, there's a possibility we perforate this tooth, and he said, no, I don't want to go ahead with the treatment, well then he's made the correct decision, hasn't he? But in this case, he knows that was the risk. Luckily, in this case, I've managed to repair the perforation. You know, there's an argument to say that I have removed tooth tissue, but I think in this case it's not a significant amount of tooth tissue. I'm quite happy with that, and we filled the apical end here very, very nicely, and overall I think it's a really, really nice result. Lastly, I just want to say thank you for watching. This has been a really, really great case. I hope you've learned something from this. If you feel like something could have been done differently, or you have any criticism in the case, please don't hesitate. Comment in the section below. It's all about learning with this channel. And again, if you haven't liked or subscribed, please like and subscribe. And I'll see you in the next video. Bye-bye.